Move on to the physiology a little bit, and we're going to have two presentations, each one of about 10 minutes. The first one by Lou, and the second one by Dong Sheng. So we'll do Lou's first here. Go ahead, Lou.
Okay, in 10 minutes, I'll give you 50 years. I'm just going to start with all the things we've learned about INS. It's non-clinically distinguishable when you just look at the eyes what they're doing. There are foveation periods buried in there. You also can't see them. There are small idiosyncratic differences in the characteristics from patient to patient or even from one gaze angle to another. Where that person is looking with respect to his peak or his null position determines which direction the nystagmus is going to go. The waveforms are constantly changing in amplitude and frequency and shape, and yet there's no oscillopsia. The INS we record is the same whether or not a patient has an associated afferent deficit. The waveforms and major characteristics of them are the same, and the direct cause of the oscillation is the same. What emerged from our work is that we have a single eye movement disorder with known measurable characteristics and a single cause. And that cause lays in the smooth pursuit system, as I'll say a little bit about later. These three phase planes show very nicely that whether a person is, I don't know if I can do that, I can't point. The top one, just fixating. The one below it, smoothly pursuing a moving target, and the one to the right in the bottom, head shaking. All the systems work very well. That's why they can do sports, people with nystagmus, and pretty much do everything anyone else can do. The oculomotor system works even though there's an oscillation. So what is the cause? We have to understand the difference between causality and correlation. Just because things exist with something or even before doesn't mean it's a cause. It may predispose the system from going unstable, but it is not the direct cause. And when I say cause, I'm always going to mean direct cause. The direct cause has to be consistent with all the things you have observed in the clinic. It's very prone to occur in the population. It can occur with any of many sensory deficits or with no sensory deficit. It can occur with variable timing, right at birth, in early infancy, or even later in life has been reported by ophthalmologists. It's the same for all of the above type patients. It's present with or without fixation. It's present in the dark. It occurs with or without strabismus. Therefore, if you talk about the direct cause, you can't link it to one sensory deficit or to strabismus. You can't say it's dependent on the maldevelopment of vision or the presence of fixation. And any cause you come up with had better fulfill a logically if and only if criteria for it to be truly causal. As I said before, many things facilitate it, but you must not fall into the post hoc ergo propter hoc logical fallacy. Just because something is there, you call it a cause. Now, if we look at the oculomotor system and the afferent visual system that drives it, we looked at all of the afferent things, and obviously they fail the if and only if criteria, because one patient may have aniridia, another patient has albinism, some patients have none. No known afferent deficit. And therefore, none of them are truly causal. We started to study the oculomotor system and systematically found it could not be the fixation part of the system, could not be saccades, could not be the neural integrated circuitry. All of this stuff is published. We found it lay in the smooth pursuit system. And the genesis for most of the pathognomonic waveforms of INS comes straight from the smooth pursuit system. Also, there's some contribution from the visual vestibular system to various degrees, which may give some linear waveforms, but certainly determines where the null is and how broad the null is. So, we can no longer use the word idiopathic. I've been trying for 10 years to get people to stop using it. especially to apply this misnomer, to a group of patients and not to all patients. If you don't believe it's in the smooth pursuit system, then you must say all INS is idiopathic. You cannot say a small group is idiopathic, which implies that all the others are caused by this sensory deficits, which isn't true. So I really, you want to, Dave had said get rid of sensory and motor. I agree. You get rid of idiopathic. What we found is that the normally underdamped smooth pursuit system, you can see a little oscillation there. That's a normal person. When you have a system that's so close to instability, it's very easy for it to become unstable. And that is why, that answers the question of why is nystagmus so prevalent with so many other associated conditions. Anatonic visual vestibular imbalance. The first one gives the most of the waveforms, and the second one really determines the position and width of the null zone. So, you have a marginally stable system prone to oscillation, and therefore that means throughout life we have to continuously monitor and calibrate that system. Any deficit present early on, when the two systems are talking to each other and modifying each other, can interfere with that calibration, and the system could just fail spontaneously. And as I said before, it could occur at any time. That gives rise to all of these waveforms, which we're not going to go through one at a time, and some other waveforms that come from the nucleus of the optic tract, a high frequency, low amplitude oscillation, which can superimpose on the INS waveforms. But the key here is that there are certain ones with a red star here that are pathognomonic for INS. You make a recording, you know immediately what you have if you find any of those waveforms. So let's move on to the diagnosis. Clearly, eye movement recordings make a definite diagnosis in all cases, no problem. The problem is not many of you have this ability, or even the ability to send your person to the local EKG lab or the local EMR lab. Clinically, you can sometimes make this diagnosis with absolute certainty, other times with high probability. But there are times, there are groups of characteristics that make it impossible to determine exactly what the patient has without eye movement recordings. When you record someone's best corrected visual acuity, and when I say visual acuity from now on, I mean best corrected visual acuity, you must understand that acuity you recorded has two components at least, forgetting the optical. Let's assume it's all correctable optically. A sensory component and a motor component. And INS patients have both of these. And if you record best corrected visual acuity, you can't tell the difference between a person that has a very good waveform and very poor optic nerve, or vice versa, or maybe both of them are compromised. We developed a function that can single out the motor component to the number you got in the clinic. What part of that best corrected visual acuity is due only to the nystagmus? That's really important to know, the foveation quality. Once you know that, and you know the acuity you measured, you can deduce the sensory component. And that's not going to change with surgery on the muscles. So this NAFX, we have here the velocity on top, in the middle we have the position, and what's identified in red are and the position curve, everything that falls within a certain foveation window, the velocity curve, a velocity window. An algorithm automatically takes the two and finds simultaneous satisfaction of both criteria and dumps all the rest of the information and performs a statistic only on those little blips of information during the foveation periods. And what you get is a number between 0 and 1 that's linearly proportional to Snellen acuity expressed as a decimal. There's some age variation and obviously a species variation. Once you know the patient's age, you know which line to use. The other thing we have to understand before we progress to therapy is that this is not a good picture of the oculomotor system, the classic models. What really is happening is there's proprioceptive feedback and a brainstem control of the gain of the oculomotor plant, and that feedback system is what you're going to affect by your surgery, not the main system. So when you think about therapy, therapy can be either at the source, like as in the case of Leber's congenital amaurosis, where genetically they're fixing the primary problem, or you could give a systemic drug which applies in the middle. But most of the therapy we use, and is currently being used everywhere, is peripheral therapy. We're working on the extraocular muscles, and that is what I'm going to spend my time on. We've been able to study how much improvement we get in waveform using the NAFX, just the motor component, based on the pre-therapy value of the NAFX, and it forms some sort of curve like that. Not earth-shattering. A high NAFX means you already got a very good waveform. You're not going to do much, if anything. But the lower it gets, the higher the percentage improvement you can get, to very high percentages. Now, the same thing applies to something even more important than that. Instead of the peak NAFX, how broad is that curve over gaze angle? And you got the same kind of curve. Obviously, if the person can see well on both sides of his null, you're not going to improve that very much. But if you can't, if it's narrow, as in most cases, you're going to get a big improvement. Let's put together several studies, and even the little X throw in an acquired nystagmus, and we find out that this surgery is independent of the kind of nystagmus you have, and as the numbers indicate, it's independent of the age of the patient. But even more important for therapy, it's independent of the associated afferent deficit. Here we have some patients with no associated afferent deficit, some with albinism, some with achiasma. They all fall along the same curve. That means you can expect the same percentage improvement as someone, as the girl that Dr. Granite talked about, who had very poor vision because of other problems, as you can expect from someone with only INS. So we can now estimate the post-therapy improvements based on these pre-therapy measures, the NAFX measure, and we know they're independent of age and associated afferent deficits. So the message for that is, just because a patient walks in with very poor vision and one of the many afferent deficits, that is not a contraindication for therapy. As a matter of fact, the percent improvements are likely to be higher and much more appreciated in that patient than in someone you got from 2040 to 2020. Here are some systemic drug, acetazolamide, and you could see the difference in pre and post. It's about a 50% improvement at all gaze angles. And you can see where the acetazolamide falls along the same curve we did for surgery. You'll notice convergence is a better option. If you could ever use convergence, the patient has no strabismus. That usually gives the best improvement in peak and the best improvement in the breadth of that peak. And here's the longest foveation domain, the acetazolamide again falling right on the curve. In addition, we've tried some brinzolamide topical eye drops, and this is just one person, and they fall also around the same curve. Rich may talk about some other eye drops later. What you see in this curve is, on the top curve, the broadest and highest is convergence. The bottom curve is pre-therapy, and you can see, I believe it's soft contact lenses, and the red is the brinzolamide. Notice we get an increase in the peak, but more important to the patient, you're getting a broad range of very high acuity for that patient, his highest, whatever it is. So in all INS patients, soft contact lenses may be very good. We may develop some eye drops in addition to brinzolamide. If the binocular with convergence damping base out prisms with -1 spheres added, you've got to add them, and you've got to tell the patient when you get older, you're going to have to come back and we'll take out the -1. Bimedial recessions are the best if you can use them. 4-muscle AK surgery for large deviations, the null is very lateral. A 2-muscle plus a 2-muscle TNR for small. And for no nulls or central nulls or APAN, the 4-muscle TNR. Obviously, you can combine the shifting with the convergence if a person has no strabismus, and you'll get the best results. I leave you with this picture because I want to emphasize the problem a person with nystagmus has is not in central vision or even wherever his peak is. It's in lateral gaze. That's where they are effectively blind. They look over there, they don't know who they're looking at. And the improvement you see in the post-therapy, even though there's some improvement at the peak, that's much less important than the improvement in lateral gaze. That's why I say you must measure 7 visual acuities pre and post-therapy, and you'll have a clinical measure of the improvement. The important thing is they can see more, not only better. And thank you.
Thanks, Lou.